All right, welcome to this explainer. Today, we're looking at something that honestly feels like a downright medical superpower. We're completely demystifying basic cardiac ultrasound, specifically for emergency echocardiography. Think of this as your personal, quick start instruction manual for literally seeing the unseen when seconds matter most.
Okay, let's dive into this. Right off the bat, I really want you to see this quote from the European Society of Cardiology. They say, emergency echo should be performed by anyone who knows how to get valuable information from it and use it in the decision-making process. I mean, that's incredibly empowering, right? It means this isn't some gate-kept skill just for specialized cardiologists. It's a crucial, highly accessible tool for anyone on the front lines willing to learn how to grab and read these images.
Because, well, here's the incredibly intense reality we all face. When a patient with unstable cardiovascular disease is crashing right in front of you, how do we actually know if the heart is pumping adequately? How do we figure out exactly what's failing inside that chest cavity in real time? We need answers, and we need them right now, without waiting for some invasive procedure.
To get those answers, our source material hands us a complete clinical tool belt. Here is our roadmap for today. 1. Why emergency echo matters. 2. Mastering the ultrasound probe. 3. The 4 basic cardiac views. 4. Evaluating ventricle size and function. 5. Spotting effusions and volume status. And 6. Crucial pitfalls and takeaways. Now, as we go through this, keep an eye out for a heavy reliance on the rule of fours. You'll see it everywhere in this clinical guide, and it makes the entire protocol super easy to remember.
Let's start with Section 1. Why emergency echo matters for non-invasive assessment. So the crucial point is that everything we do with the ultrasound probe comes back to non-invasive hemodynamic assessment right at the bedside. It's all about answering these 4 core questions. Number 1, is the left ventricle functioning adequately? 2, is the right ventricle functioning adequately? 3, is there any pericardial fusion or cardiac tamponade? And 4, what is the overall volume status? Memorize these because these 4 questions are the absolute anchor for every single measurement we're about to learn.
Moving right along to Section 2, Mastering the Ultrasound Probe, specifically the phased array transducer.
Before we look at the heart, we've got to understand our literal physical tool. We're using a phased array probe. It operates at a frequency of 2.5 to 5 megahertz, and it's got this small, flat footprint that is just perfectly designed to peak right between the ribs. But to use it, you need to master the 4 cardinal transducer movements. Actually, treat this like you're learning a physical sport. First, you have sliding, literally moving the footprint across the patient's skin. Second is tilting, angling the beam without moving the footprint itself. Third is rotating, twisting the probe clockwise or counterclockwise. And fourth is rocking, pointing the beam toward or away from the probe marker along its long axis. Dialing in these 4 rapid physical movements is exactly how you unlock a perfect, life-saving view. Which brings us to Section 3, the 4 basic cardiac views. These are our acoustic windows. First up is the parasternal long axis, or PLAX view. To get this, we place the probe at the 3rd or 4th intercostal space just to the left of the sternum. You want to aim the marker directly at the patient's right shoulder. Now here's a pro tip. When you dial in a really good PLAX view, your interventricular septum should be as horizontal and parallel to the screen as possible. This is just a phenomenal window to quickly check out ventricle function and watch the mitral and aortic valves do their thing. Next up, we rotate that probe 90 degrees to capture the parasternal short axis, or PSAX. Now what's really interesting about this slide is the brilliant visual metaphors it uses. When you fan the probe, you slice the heart cross-sectionally. Down at the papillary muscle level, the mitral valve looks exactly like a fish mouth opening and closing. If you angle it up toward the base of the heart, the aortic valve looks precisely like a Mercedes-Benz logo. These fun shapes make rapid pattern recognition incredibly fast in a high-stressed environment.
Our third window is the apical 4-chamber, or A4C view. You put the probe right at the apex of the heart. Now, getting this one perfect usually requires a bit of manipulation. You want to roll the patient into a left lateral position and have them elevate their left hand to drop the lung out of the way. Do that, and you're rewarded with a beautiful, simultaneous look at all 4 chambers, complete with a perfectly straight, vertically centered septum.
Finally, window number 4 is the subxiphoid view. We drop down just below the xiphoid process, lay the probe almost totally flat at a 15-degree angle, and look up through the liver. Because the liver is a dense, fluid-filled organ, it acts as the ultimate acoustic window. I really have to note here, this view is exceptionally reliable for spotting pericardial effusions. It's a total game changer during a trauma or a cardiac arrest when getting to the top of the chest is just too chaotic.
Let's jump into Section 4, Evaluating Ventricle Size and Function. So, let's shift focus back and answer those first two core questions. How are the left and right ventricles actually performing? And this brilliantly illustrates how distinct the anatomy is. Look at the stark contrast. The left ventricle is the workhorse. It's rounded, shaped like a cone or rugby ball, with thick muscular walls and a normal diameter of less than 5 centimeters. The right ventricle, it just kind of wraps around the LV. In a short axis view, it looks like a crescent moon, and in a 4-chamber view, it's triangular. Its diameter should be strictly less than 2 centimeters. Recognizing that cone versus crescent shape instantly helps you figure out if the RV is becoming dangerously blown out.
Now, when we need to actively quantify right ventricle function, we use TAPSE, tricuspid annular plane systolic excursion. Sure, it sounds like a mouthful, but you're simply measuring how far the tricuspid valve moves up and down during a heartbeat. 16 millimeters. That is your critical danger zone. If that vertical bounce is less than 16 millimeters, your patient is at high risk for RV systolic dysfunction. It's a hard, absolute number you've got to burn into your brain.
Section 5. Spotting effusions and volume status.
Okay, we're going to pick up the pace a bit here because we're entering the high-stakes territory of shock and clinically relevant hypovolemia. To assess volume status, we look down at the inferior vena cava, or IVC. This grid maps out IVC diameter and collapsibility for both breathing and ventilated patients. In a spontaneously breathing patient, an IVC under 0.9 centimeters that collapses more than 50%, they are likely fluid responsive. If it's over 2 centimeters and barely moving, they probably aren't. But listen, the absolute golden rule from our source material here is to stick to the extremes. The middle ground is just way too unpredictable. Flat IVC? They need fluids. Massive, totally fixed IVC? Stop the fluids.
Now, what if fluid is accumulating outside the heart, trapped inside the tight pericardial sac? Normal pressure there is just 0 to 8 millimeters of mercury. But as fluid pools, once it hits around 100 milliliters, it surrounds the whole heart. Pressure rapidly builds to 15, then 30 millimeters of mercury. Suddenly, the pressure outside the heart is greater than the pressure inside the right-sided chambers. This terrifying, escalating pathophysiology leads straight to right atrial systolic collapse, followed immediately by right ventricle diastolic collapse. This is cardiac tamponade. It's literally a fluid vice grip on the heart, backing blood up into the system and giving you that engorged, fixed IVC we just saw. Finally, Section 6, Crucial Pitfalls and Takeaways. Let's slow it down for some much-needed caution.
Let's move to and see how this builds, because the images you're capturing carry massive clinical weight. So caution is absolutely mandatory. Your scan findings must always correlate with your overall clinical assessment. POCUS complements your holistic clinical judgment. It never replaces it. Remember, that IVC fluid assessment has real limits in those gray areas we discussed. And you've got to be super careful if a patient has severe valvular lesions or chronic heart pathologies, because those pre-existing conditions make these basic visual assessments way less reliable. When in doubt, you must always consider referring to more experienced sonography personnel.
So, we've walked through the 4 core questions, the 4 probe movements, and the 4 primary views. I want to leave you with this provocative thought. If a patient's hemodynamics collapse tomorrow on your shift, are you ready to pick up the probe and see the unseen? The tools are accessible, the rule of 4s makes the concepts incredibly clear, and the power to make life-saving clinical decisions is literally sitting in the palm of your hand. Review these concepts, master those views, and until the next explainer, keep learning.